So welcome to session 3 of the World Sepsis Congress 2021. This is obviously a different World Sepsis Congress to those that we've run before because we are in the midst globally of a pandemic. Some countries believe or have responded well. Some countries perhaps believe they have or indeed have responded less well. So really this session's around what we can do as a global society. Are there any shining examples of countries, governments, individuals that have responded brilliantly to this campaign? Are there any lessons we can learn from errors we've made along the way? So this session's entitled Lessons Learned for Ending This and for Preventing the Next Pandemic. My name's Ron. I'm an intensive care consultant in the West Midlands in Birmingham in the United Kingdom. I'm one of the vice presidents of the Global Sepsis Alliance. I've been involved in championing better sepsis outcomes really since, I believe, 2005. I'm here to moderate this session, and I think this just reinforces that we are in the midst of a pandemic. For those of you who've had a program in your hands on your laptops over the last several weeks, there have been some changes to this program. So it's important to reinforce to you that Dr. Ruocco and Professor Vila, respectively from Italy and Germany, have had to very sadly withdraw from this session this afternoon, my time, because they are heavily involved in their country's response to the COVID pandemic. And Maria Van Kerkhove from the WHO, she's unfortunately also had to withdraw, and she has genuinely a family emergency that she can't get over. But the great news is that Dr. Friedrich, that Marcus Friedrich from New York in North America, he's agreed to join us to share his perspective and add his reflections. But I'd like to start by inviting a friend and colleague, Gareth Presch, to offer his initial reflections on the lessons we can learn from this pandemic, how we can help to end it, working together as a society, and what we can do next. To introduce Gareth briefly, Gareth is really a global healthcare thought leader. So he's the founder and chief executive officer of the World Health Innovation Summit, the expert lead on the Sustainable Development Goals 3 and 4 for the UNGSAI Foundation, founder of the Global Social Prescribing Alliance, and a member of Pope Francis's Vatican COVID-19 Commission Group, looking to the future. So Gareth, if you please, and I apologize that you're taking the place really of three esteemed colleagues who sadly can't make it, but what initial reflections and thoughts ahead are you able to offer around this pandemic?
Thanks, Ron. Firstly, my thanks for the invitation to speak to everyone today. And I think this really is an opportunity. When we look at the future, how do we face the challenges that we will face in the future to avoid future pandemics? And I thought I would start by just a little bit of a reflection. And if we could just, on my slide, you probably see in front of you there, slide 1, you can see that we have actually been forewarned. And we've had opportunities in the past to kind of plan, and I hope in the future we can get it right. So, I'm looking at how critical are public-private partnerships in planning for pandemic preparedness. In 2019, there was an event 201. There was a number of recommendations made around public-private cooperation. And when you look at this in terms of the points and the recommendations that were made, it was a significant opportunity by governments and civil society and the wider, shall we say, public-private partnership opportunity to come together and bring these recommendations to the fore to ensure we didn't have, shall we say, such an impact across the globe that we're currently facing through COVID-19. And I just want to start on some of these points. I mean, my initial thought was just to highlight some of these, and I will. But just if you look at point 1, governments, international organizations, and business should plan now for how essential corporate capabilities will be utilized during a large-scale pandemic. Point 2, industry, national governments, and international organizations should work together to enhance international health stockpiles of medical countermeasures. to enable rapid and equitable distribution during a pandemic. I mean, we're seeing that with the vaccines at the moment. You know, countries, international organizations, and global transportation companies should work together. And there's more points, and I don't want to go through each one of them. But what I'm saying here is that we have had that opportunity to be prepared. And that's one of the biggest lessons that we face at this present time. I think when we look to the future and the opportunities in terms of next steps, and my next slide is really around what comes next and how do we actually leverage this support, and we look at the lessons learned. Well, you know, COVID has displaced 400 million jobs. But at the same time, there's been a great mass of wealth generated. Billions of pounds literally tech companies have made. And while I'm looking at it from the Sustainable Development Goals perspective and the SDGs and working with the UNGSII Foundation, we've been also looking at how do you leverage that, what we would call intangibles, into investments for Sustainable Development Goal 3, which is good health and well-being. And healthcare, and what I've seen the previous sessions, it's been great to see that we're actually at the forefront of this, building trust within communities, tackling misinformation. Ron, you've done a great job in the UK in terms of that misinformation and tackling it head on. But can we leverage this, goodwill within communities, the health sector leading on building trust within communities? Can we also look at how do we develop good health and well-being? I mean, huge challenges are coming down the line in terms of staffing, recruitment, retention. One of the areas that we've kind of missed is, we have an 18 million staff shortfall by 2030. Now, many people will say that's a huge challenge. That's actually an opportunity. When we look at AMR, when we look at disease management, global burden of disease, we should also look at how do we promote good health and well-being? How do we support communities to enable and to react effectively and efficiently to support our local health services? And this also looks at value creation in terms of leveraging the current $12 trillion market space, which is involved in health and well-being around the world. How do we create a circular economy? And that's really what I'm looking at, is creating that value opportunity for health and well-being across multi-sectors, patients, clinicians, managers, voluntary sector, education, and the business community working together. I mentioned the SCR 500 there, which is the report that we will present the cumulative results, which is a fund we've been working on with Alfred Berkeley, former president of NASDAQ, to the G20 next month in Berlin with Dennis Snower's team, Global Solutions, in Berlin. And we'll be able to demonstrate that there is a significant opportunity to invest in sustainable development goals and create new and meaningful jobs while addressing these concerns. So that's what we're looking at, and that's what we intend to leverage. This is important because we have to anticipate the future. We know our populations are rising. We know we have to support 10 billion people on the planet. We also know that, climate change is upon us. If we think we have challenges now with COVID-19, how are we going to address these, offsetting carbon footprints? There are huge opportunities. We haven't really discussed the influence of the fake groups. How can they get involved? How can they support? And I think this pandemic has really shown that we have to have a holistic approach around good health and well-being and make healthcare sustainable. I always, I come from a managerial background, patient safety as well. We always talk about the costs. But again, I want to try and say to people, let's look at the value that's being created by putting in preventative measures. We can put in these disease surveillance and so on and so forth. And my final slide really looks at, us working together collaboratively, which is, about going on that journey towards me and you working together and us in the community working together so that we solve these problems. The great thing about what we're doing at the moment, Ron, and even today's discussion, is the fact that we're bringing solutions to the table. And there are solutions, there are wisdom, there are knowledge there. And it's really about us as a collective unit taking that leadership step to make these things happen. We're already we are aware that the finance is there. I mean, from the World Urban Forum last year, we were told that the money is there to support SDGs. But the problem we seem to face is being able to match the players. We have to get these people to communicate together. And that's very important when we look to the future of health and well-being. So, I mean, from a global context, really, it's local as well, because we have to get that information and build that trust. So I hope, Ron, that gives you a bit of a context in terms of what we can do, opens up the opportunities to create new and meaningful jobs. Just an example, in the UK with the Global Social Prescribing Alliance, we're working very closely with the National Academy of Social Prescribing. They're going to invest in link workers, increase their care workers from 4,000 in primary care up to 20-odd thousand. So there's huge opportunities. But in terms of creating value, with what we've done in World Health Innovation Summit is £1 invested, 36 back. And that creates an opportunity cost around the world. So I hope that gives you an insight into the opportunities. And I'm looking forward to this discussion on how we can learn from each other.
Thank you so much, Gareth. That's, fantastic food for thought and a great opening to this session. And just as a heads up to my colleagues, I'm going to call on Marcus Friedrich next with permission. But Gareth, I've just got 3 questions for you, and I think we can open this up into a broader debate once we've heard from the other participants. I mean, the first question is, we're not very good at this stuff, are we? Who should be leading this? Should it be the UN? Should it be the WHO? Should it be national governments? Should it be corporations? Should it indeed be faith organizations? Or should it be all of these? Because when we look at organizations like the UN, like the WHO, like national governments, this embracing in healthcare of this partnership between private sector and the public sector is not very well cemented. And it's a brave new world to enter into this space where it becomes a societal responsibility, not only in terms of the humanitarian effort, but also the financial effort around this. How do we overcome this?
I think this is a brilliant point, and this is down to leadership, Ron. It's all about who has the appetite, who's willing to make those bold changes. Healthcare is risk averse. We know that it takes so much evidence to build a case. But look, let's call a spade a spade. We know what works. We have enough evidence in the bank. We know how to prevent disease. Listen, my mother used to tell me, eat an apple a day, keep the doctor away. Just simple things like that. Exercise. Let's start promoting health. Let's start look at the value that can be created. Let's keep people out of hospitals, because the reality is we can't service the people in hospitals. And we are going to face a huge problem in the next few months around staffing, recruitment, retention. And we have to be open and honest and transparent. That affects business community around the world. They need to chip in. The private sector need to understand that this will impact them commercially. It's across the board. We have to take the initiative. We have to support those that are willing to take that lead. I mean, I'm very fortunate. I work with some amazing pioneers, Roland Schatz, Michael Muller, Kofi Annan. They set up the index to support. They wanted to show that you could get a financial return based on intangibles into the SDGs. That's part of the reason why the Millennium Development Goals failed. But we need to get on board, and we need to change the mindset also. We can't have a situation where we are constantly saying, for WHO, for example, cap in hand, going to try and get finance, when finance is available at the drop of a hat to set up a European Super League, for example. So, I mean, we have to call a spade here. We need to look after our populations. And I also think one of the areas that will show significant growth and opportunity is watch the African Union and watch their members. And because the greatest need is coming from Africa, South America, and Asia. And they do have the commodities and the minerals and the metals and the willingness to look for partners. Okay. And there will be a big change in how they approach things. So there's a good opportunity there, Ron.
Yeah, and a fantastic point, Gareth. And of course, if we look at the rate of progress globally. Some of those countries that you mentioned in your closing statement are the leaders. Now, there's a question arising which is very related from one of our guests, and then I have two more short points before we come over to Marcus Friedrich. But how can private scientific companies contribute to this? What's the role of, I guess, big pharma, the diagnostics companies, the medical equipment companies, and so forth?
Well, they're all involved. I mean, we only just have to look at climate change, okay? Look at the situation that we face in terms of fish, air pollution. You know, this affects everyone. Where does contraceptive pill? Where that's flushed down the toilet. I mean, it ends up in our food chain. I mean, these are like, everyone has to play their part, including big pharma. The companies of the future, remember, we also have to look at where are we going to invest our money in the future, okay? In the past, the large tech companies we have been investing in, okay, remember, we are investing in them. The money comes from civil society by us supporting them, okay, by using those platforms. We need to support ethical and sustainable platforms of the future. That's where we put our money. Being open and transparent is the future. And if we can embrace that and work with those companies who are willing to embrace that and also have the cash to do that. Remember, I just showed you the point there on the Oxfam report. Only 0.5% of the billions of pounds that have been generated during the pandemic have been reinvested back into communities. That's absurd. The private sector need to mobilize that cash and they need to reinvest it back into health and well-being. And then they will benefit from that as well. I mean, I can sit with any one of those companies and show them the business model that can actually generate more cash flow. This is an opportunity in terms of every single corporation around the world, the top 500 S&Ps. But Ron, in the next 10 years, we'll have new companies come into that space. That dynamic can change very quickly, which is what we will see in the future.
Fantastic. Great answer. And just an observation from one of our guests. So thanks for the transparency. That's so true and real. The other questions that are arising, I'm going to save until after we've heard from our other speakers, but rest assured, I am retaining them. So just 2 points from me, Gareth, if I may, just picking up on a couple of things you said. This whole public engagement and public interest in health that has led to really so much disinformation on social media. And I think, perhaps some governments with reflection might concede in time that they have led messaging that's been largely driven by fear in order to control the public. That's probably propagated a lot of this disinformation on social media. So my first question is around that. How do we manage that as we move forward? Because those people on social media are not going to disengage from health policy and health matters over the coming years and before the next critical event. But how do we manage them and make them more formative and more engaged in a positive way? My second point about what you said was the effect on healthcare staff. I've seen colleagues on long-term sick leave, through anxiety, through stress, through physical sequelae of COVID-19. I've seen colleagues leave for sabbaticals, leave for a different career path. This is not restricted to my hospital. This is going to be the case in every healthcare system around the world, because health professionals are now mentally and emotionally and physically exhausted. How do we manage that situation? So, sorry, 2 questions, Gareth, in one.
Yeah, the first one is around misinformation, and platforms have a responsibility. I mean, I think, you have to understand the great wield of power that these platforms yield, in terms of their reach. But we also have to look at opportunities within the faith groups. And we have to invite the faiths into the conversation. We have to welcome these challenges as well. And we have to state the facts. Let's just be totally honest here and state the facts, okay? As we've got to be transparent in what we're doing. And why not publish the data? People have fears. I've worked in this industry for 20 years. I've been fortunate to meet people like yourself, Ron, who work with honesty and integrity. Yes, we do make mistakes. But the reality is we are trying to help people. That's why I joined the health service. It's given me a fantastic career. And that's what I want to do. I want to help others. In the second point, in terms of burnout and in terms of what we're looking at in well-being, again, this comes back to cultural issues within the health service. Again, it's a challenge. but it's also an opportunity to look at the value of staff. Remember, I don't know how many times, the health system is bled dry from its intangibles, from its intellectual capital. It's property that is there, that has been sucked dry to commercialize around the world. We need to look at that. We need to look at that from the point of view of how do we tap into that resource? The staff are so willing to help people. Like you say, they burn themselves out. We have a staff, most people who join the health service are empathetic. They are in the top 2% in the world academically. And so they join because they want to help and do good work. We have a right and a responsibility to look after that and also share that knowledge and wisdom. That's the huge opportunity that we have in the future. One final point to make as well around financing and funding that I want to make is just remember, Jeremy Hunt mentioned earlier, the NHS has 1.4 million staff, okay? The financing of the NHS is through pension funds. And we also have to look at how do we finance healthcare going forward in the future, the return on investment, the value created. These are areas that we need to explore because they have huge opportunity.
Fantastic answers, Gareth. And I'm just going to, if I may, take the liberty of summarizing your session with, a couple of keywords, really: honesty, integrity, and really the challenge you've presented to governments, to health professionals, to global organizations to begin to think differently and to begin to think commercially in the interests of mankind around this. And I suppose the closing remark, if I may, is, can we afford not to do this? I would suggest that we can't. I'm not ignoring the questions around low middle income countries. I'm not ignoring the huge numbers of people we've got representing, particularly Latin America among our audience. We're going to come back to that and come back to questions such as, does this need a global or a national response when we're trying to help countries with constrained resources? I'm going to turn now to Dr. Marcus Friedrich. Now, Marcus will need little introduction, if any introduction, to many. He's the Chief Medical Officer for Patient Safety across the New York State Department of Health. So essentially the CEO for New York State, CMO for New York State. He's been leading the COVID-19 response. So Marcus, if I may ask you to, you've very kindly stepped in really at the last minute to replace, well, 3 sessions, but I think your focus and your expertise will probably be directly related to Professor Vila's session, Dr. Rolko's session, respectively coordinating surge responses nationally and leading at the front line of an emerging pandemic. So could I impose on you to please share your thoughts, having not been prepared for this session until today, Marcus?
Yeah, thank you, Ron. And again, thank you for having me. You asked earlier if there is a shining example, and I just want to take that up front that I don't see our response as a shining example. I think we were in New York struggling like everybody else around the world. Just to give you like a fact that like at the height of, we were a hotspot back in March and April here in New York and New York City. And COVID, like always, almost like I like to use soccer analogies, like doing a dribbling. It started in Washington State, and then we concentrated as a nation here in the US mostly on China, but at the same time, there was wide community spread in New York. And at the height of the surge here in New York, we had about 20,000 of our 50,000 hospital beds full with COVID. And, that is a statewide number. Most hospitals, as you probably seen and heard in New York City, were out of beds. They did a tremendous job increasing the capacity to accommodate all those patients. We had about 5,500 patients in the ICU in every single day, and that exceeded our pre-COVID ICU capacity by about threefold. And again, just to the remarkable work of the health systems around this. And also, the intubation. And I, like many others in this pandemic, got pulled into more from the logistic and procurement side, which was very interesting because I'm an internist, a practicing internist and doing HIV care, but I have very little to say when it comes to ventilators, but I was tasked with helping the state to purchase ventilators and medical equipment on a large scale. So everything had to be supercharged. We all found ourselves in different roles, as probably all of you out there as well. And you ask about kind of like key lessons. One of the lessons that I want to highlight is the data environment. As you know, Ron, we are collecting data on sepsis since early 2014, and we were very proud of our clinical abstraction, but it didn't help us one bit during COVID. The data was old. It's usually a time lag of 6 months in it, and you needed to make decisions on real-time data. So we had to build data systems from scratch to get adequate information from the hospitals, to get adequate information about bed capacity, about ventilator use. And that was really one of the big lessons, that our data infrastructure, where we were so immensely proud, that this really needed a big overhaul. And that is also probably one of the lessons that we take home, that we really need to look at data, because everything is driven by data. Every decision that we need to make is driven by data. The other piece and lesson that showed or was very clear, the issue about health equity and equality. And it's been shown, and many studies have shown that especially the Black and Hispanic population, not only in New York, but I think nationwide, was disproportionately affected by this pandemic. And I think that this also led us to think more about health equities in general, and also thinking about how can we address this more than before. And there are various initiatives on its way from the highest level to take a new look at health equities, because I think that this is really something that we want to combat and want to have as one of the strategic goals in the next 5 to 10 years, to really understand why this is happening, and also how to combat and hopefully eliminate this going forward. And then, of course, the other lesson is the preparedness, that everybody was kind of like flat-footed from the PPE, or was found flat-footed from the PPE that was lacking in many of our facilities, that we had to scramble. And I found myself competing with the Chinese, with the Europeans on the world market to get these supplies. And it was really bothersome that because of these concerns in the past, the global supply chain completely broke down, and we were scrambling to give our frontline workers adequate PPE, which we at the end we resolved, but it was a challenge, especially in the beginning when COVID virtually exploded here on the shores in the United States. So those are kind of like just my opening comments. I personally, I must say that I'm very proud for the work that we've done here at the department. Nobody did it right, and we were, we showed flexibility, and we, finally bent the curve down. And, we had, after the first surge, a very good summer. During the holiday surge, thank God, with all our measures in social distancing and so forth, we were not hit as hard as many other areas in the United States. So that was a positive. And we will see now how this pans out going forward.
Thank you so much, Marcus. These are fantastic insights, and I'd really encourage people to ask questions related to your session. We've heard from Gareth, who's got a global perspective. We're going to hear from Jérôme shortly around the perspective across the country in France. But it's rare that we can have direct interaction with leaders who've been responsible for delivering these responses at a regional or national level. And, fantastic honesty there from you, Marcus. The mistakes that all countries have made, particularly on the procurement side of things. I'm going to ask you a little bit about the equity and a little bit about the data as well before we move on to Professor Salomon. But you acknowledge that we've all learned lessons around ventilators. We've all learned lessons around PPE. And my reflections from the United Kingdom were that ventilators were the immediate priority of the government. We were told by colleagues in China, by colleagues in the Lombardy region of Italy, we were going to need a lot of ventilators. I feel that this is something that's really quite tangible and, dare I say, almost a bit sexy for governments. Our government asked for a collaboration between the McLaren Formula One racing team and Mercedes-Benz to produce some ventilators. That's kind of sexy. That's kind of a press statement. It's going to engage people. PPE, well, it's a bit less sexy, isn't it? It's around protecting healthcare workers. We know that they're terrified. We want to protect them, but we also want to know as a member of the public that there's going to be the equipment there to treat us. How do we learn lessons from this and prioritize procurement according to genuine need in the future without first prioritizing those more sexy items?
We had our share here. I think Elon Musk and Tesla, and also General Motors started building ventilators. And at the end, who really came through are the existing manufacturers of ventilators who ramped up their production facility. I think that as you said, Ron, it was interesting to see kind of like that everybody suddenly had an idea to solve that ventilator question. And, I was on the receiving end, and probably 99.999% of these ideas were total garbage that were not usable at all. While at the same time, patients needed to be ventilated in the hospitals. So I think it requires also a way of looking at this procurement process. And as you know, as a public health agency that the Department of Health here in New York is, we were usually not in the position that we had to procure large amounts, but it like the pandemic showed us that we need to be in the driver's seat to make sound clinical decisions on what needs to be procured. And I think that was a misconception in the beginning that the procurement needs to be concentrated, and I don't know how it is in Great Britain or around the world, by other agencies who have virtually no clinical understanding of what is needed. And so I think, again, as a lesson learned, we learned that we need to be involved in these processes that are usually, in a completely different corner of the state, the decisions are made, that we need to be involved on the clinical side, because I'm honestly said that even though we had clinical oversight, we still bought ventilators that might have not been bought during normal times. And so as a strategy going forward, I think we need to empower the public health agencies and you mentioned earlier the institutions that we thankfully have in place, but due to reduced funding in the last couple of years, really didn't live up maybe to their standards, that we need to involve these institutions, especially these public health agencies, in this process of procurement and also emergency preparedness, which is also like a very separate issue around planning for future pandemics. And I think that there is a new openness, what I sense here in the state, but also nationally, to talk about these things and making sure that we are prepared for the next pandemic. Hopefully it's far away and not in my lifetime, but again, I just want to put that out.
Yeah, no, I think that's a great and, again, very honest response, Marcus. Someone's just commented that we should process map the patient journey and understand what procurement needs we will have through that process mapping exercise. And sometimes I would suggest, and I'd value your thoughts on this, that existing agencies that deal with public health, existing agencies that deal with infection surveillance, probably aren't the right agencies to lead in those very granular, very frontline process mapping type exercises. I'd value your thoughts on that.
Yeah, I think that is a great suggestion, and something that something that where we are not very good at, and we need to be probably trained at this process mapping. You can call it social engineering, or like what Gareth was saying about his work as an innovator in a way. And I think that these are different roles that we have to learn in the future to make sure that we adequately plan and also adequately be able to make these decisions going forward.
Yeah, agreed. You talked about equity, Marcus, and this is hugely important. I mean, certainly in many multicultural developed countries, we saw this issue that a lot of frontline workers, and one of our guests asked a question around protect, or made a statement that we should first protect the frontline workers, are from the BMA community. They're from vulnerable groups. So in the UK, we had huge numbers of cases very early on in the first wave of the pandemic among people working in busy factories, people working in public transport. It wasn't just healthcare workers. These organizations, these roles, of course, are key to keeping any country moving. These very frontline, public-focused, very often poor working conditions roles. How can we ensure that we prioritize the protection not only of vulnerable groups in terms of their ethnic and socioeconomic demographic, but also vulnerable groups in terms of the prioritizing their contribution to society, and understanding that a lot of these frontline roles are every bit as important as people who are successful in the financial services industry?
We put a lot of emphasis on testing and bringing the testing into these communities direct. And I think that is something that we made the decision very early on, that especially with COVID, with the pandemic that is highly infectious, that you need to have the adequate testing, because people are working. They might not be able to go to a testing center that is only working or opening 8 hours or 12 hours. So we put a lot of emphasis when we build testing centers, state testing centers, that they would run, some of them at least, for 24 hours, that people who are working night shifts have the ability or day shifts have the ability to come in. The other piece that we are now seeing is with the vaccine, and it's kind of the same approach. You want to go into these communities and not make sure, like, do it the other way around, where you just say, no, everybody has to come to a central test or vaccination site, but go out in the communities, align with community leaders in those communities. And I think there's a lot of effort that we made, and the governor is making, to really go and, like, we have, for example, vaccination sites in Black churches around the state. We have vaccination sites really where these people live. We have vans that are going around to help vaccinate. And so I think these are approaches to at least address the problem. Are these the final solutions going forward? Probably not. And I think that is where I'm getting at when we say that this is like a high priority for us to research this more than in the past, and also address this issue and improve the quality for this vulnerable population.
Fantastic, thank you. And people are quite reasonably commenting, well, who could imagine a pandemic of such magnitude? Is it really over? You know, we can learn lessons, but are we ever going to be really prepared? People are really interested in the mental health of healthcare workers, but there is a session later on this, session 6, the voice of healthcare workers. So I think we're going to park that. We do need to move on. I have just one more question specifically with relation to your experience, Marcus, and then I think Gareth would like to make a point, which I think is going to be really interesting, and then we must move on and listen to Jérôme's experience, and then we can open the discussion up. So the question specifically to your experience, Marcus, is what lessons drawn from COVID-19 may impact the way we should deal with sepsis?
Yeah, this is great. And this is a question that I asked myself after I had some time to breathe after the first surge. And I think that the approach, how we are thinking about handling it, first of all, I mentioned data, that we will stop more the clinical abstraction and move to a full electronic abstraction that gives us the scale and also reduces the burden on the hospitals. And we are going at our efforts now here and switching over our sepsis data collection to a full electronic platform. And I'm excited to see how this will pan out. The first data we are expecting in June and July from the hospitals, and we will see. This is really exciting. And I think for all of us, because this is a Sepsis World Congress, sepsis and COVID are somewhat related, at least in my book. There are the straight sepsis cases, there are the straight COVID cases, but as you know and others know, that there is enough research on, there is this overlap between viral sepsis, but also COVID cases who have some bacterial underlying in that. And I want to be able in the future to capture that. And therefore, I'm combining our efforts that we do on the sepsis side with the efforts that we want to do on the COVID side, because this is so important. And as sepsis has shown us, and with the high mortality, although the COVID mortality is probably less in the hospitals, but it is an emergent infectious disease, if you will, and therefore just saying that we are just looking at sepsis and not taking the experience that we had in COVID into account, I think would be a mistake. It would be too easy to get away with. And therefore, I'm and my team here at the Department of Health are putting everything into this more like digital, more real-time data collection in the future, also to get some insight about treatment and making sure that we address and have the data to make decisions and improve our quality going forward.
Yeah, there's lots of questions about the data, Marcus, but I think that might be getting a little bit too detailed for such a high-level discussion as we're in at the moment. But if we have time, we'll come back to the questions on the data. I mean, my personal view on this is a huge opportunity for anyone wanting to champion improved outcomes from sepsis, from infectious disease. The public have never been so engaged in discussions around infectious illness as they are at the moment. So I think it's a huge opportunity. Gareth, you had a point you wanted to make, and then we should move on to our other colleague.
Yeah, just two quick points. I think, Marcus, you touched on, and Ron, just in terms of data collection, what an opportunity to look at gamification for early diagnosis in terms of cognitive response. I do know that there's NHS England are looking at certain digital tools at the moment. Happy to share the links later. I think it's called The Key. And the second point that Marcus talked about, procurement, and in terms of high value net procurement, I was part of the National Haemophilia Council in Ireland, which looked at hepatitis C and contaminated blood products. We were buying factor concentrate from pharmaceutical companies, but the patient groups were very much in part of that group, and then they brought huge value. So that is a huge opportunity, Marcus, in terms of public procurement, to engage with the patients, to have them with us, because they bring a valuable insight into driving costs down.
Thank you so much, Gareth. Again, very fascinating observation. So we're going to move on to Professor Jérôme Salomon. He will need no introduction to most people. He is the French Director General for Health, a position he's held since January 2018, as well as an elected member of the World Health Organization Executive Committee. Professor Salomon seems to have a clinical background which would take most of us 100 years to achieve in being a full professor of each of public health, epidemiology, and infectious disease. So, Professor, please, I believe you're going to talk to us about how we've managed or how you've managed national state of emergency across France.
Thank you very much, Mr. Chairman, dear Ron Diners. for the invitation and the organization of this session and moderating so well. As you said, I am MD, MPH, PhD, and a specialist of infectious and tropical disease, and I've been asked to become the General Director for Health in France 3 years ago, and I didn't know I had to struggle against this pandemic. So I'm deeply sorry not to be able to congratulate and participate with my colleagues from Italy and Germany, Dr. Rocco and Professor Wheeler, but I'm very happy to listen to my colleagues, Gareth and Marcus, and it was really very, very interesting for me. As you know, I am heavily involved in the COVID response in France as crisis director, as we said, or scientific director, and you may know, we are facing a huge third surge after 2 waves in March and October. And now, with more than 80% of variant V1 in France, we have all the variants you want, V2 in the Indian Ocean, in the French islands of La Réunion and Mayotte, and V3 P1 in French Guiana. So we can have a lot of lessons and studies against variants. We have now more than 33,000 cases a day, and we are dealing with 31,000 patients hospitalized now, and more than 6,000 severe cases in ICU. So just 1 point, we now have 10,000 ICU beds, and we had 5,000 before, just 2 years ago. So it's a huge effort in France, and we have, of course, wonderful MDs and nurses and staff everywhere. And I think it's a very important point, the huge human mobilization against this outbreak. The total death toll now in France is more than 101,000 deaths in our country. Population is 66 million. And we have, as you may know, curfew and lockdown measures in place. And I wanted to say it's very important, maybe for me, to say that the importance of communication, daily communication, population education, and of course human compliance to the public health measures. And one specific point in France is the involvement of our president, Emmanuel Macron, who is leading a coordination session each week, which is quite difficult for us because we have to explain everything, and it's a really huge session with all points of control, of epidemiology, treatments, and vaccine who are explained and we are challenged. And he did it since March. So as you may know, we are now with our 50th session, and it's very, very interesting. And he is very interested and involved in managing the outbreak. So I had, of course, a lot of points in common with my colleagues about the new data systems from scratch, the importance of big data and open data, the new test system in the labs. I think it's a huge effort. We are now doing more than 3.5 million tests a week, and of course a lot of efforts in sequencing. I think that's really, really very new. So maybe just to explain maybe the main lessons for us. I think the COVID-19 pandemic has been a stark reminder that Europe is not immune from devastating emerging infectious diseases. At the same time, it has shown the power of information sharing through Europe, for example, but also for many countries, and the convergence of energies, efforts, and resources across member states in the European Union. The strategies of the European Union and the World Health Organization help strengthen national health systems for an optimal response to COVID-19 and future health crises. As you may know, France has always been a pioneer and promoter of universal health coverage. The fight against sepsis fits naturally into this overall strategy. France is also a pioneer in the fight to roll back sepsis, and its recent efforts in this area are regularly praised internationally. This includes the implementation of new coding methods for sepsis to improve data for epidemiological research, or the recommendations to health professionals for the management of sepsis that our Haute Autorité de Santé, our experts, should make public this year. As you may know, sepsis is a devastating disease resulting from the immune system's deregulated response to infections that leads to organ failure and potentially death. It's now well demonstrated that COVID-19 is a clinical phenotype of sepsis of viral origin. Each year, sepsis affects nearly 50 million people worldwide, more than 40% of whom are children under the age of 5. While the burden is concentrated in poor and emerging countries, sepsis also remains a leading cause of death in high-income countries. Overall, sepsis causes more than 11 million deaths each year. Yet the majority of these diseases, of the deaths, are preventable, as you know. It's estimated that sepsis is responsible each year for nearly 700,000 deaths in Europe and nearly 57,000 deaths in France. The average cost is around 16,000 euro per hospitalization. In May 2017, the World Health Assembly adopted Resolution 70.7 on sepsis that urges WHO member states to include the prevention, diagnosis, and treatment of sepsis in the organization of the health systems. The resolution calls on WHO to develop guidance on sepsis prevention and management, and on member states to define and implement standards and establish guidelines, infrastructure, laboratory capacity, strategies, and tools for identifying sepsis, reducing its incidence, as well as morbidity and mortality due to sepsis. And on United Nations organizations, partner, international organizations, and stakeholders to enhance sepsis treatment and infection prevention on control, including vaccinations. The COVID-19 pandemic should prompt national authorities to develop a national strategy to fight sepsis. In addition to a high death rate, COVID-19 exacerbates the social cost of sepsis through its long-term effects. I think it's a very important point, the long-term effects of COVID. The long-term consequences of sepsis are well known. Up to 50% of sepsis survivors suffer from physical, cognitive, and psychological damage. It's increasingly established that patients with COVID-19 are at high risk for similar long-term consequences, such as chronic fatigue, muscle weakness, loss of smell, difficulty concentrating, and loss of autonomy. If several countries are increased their attention to the issue of sepsis, to date only a few countries have taken concrete measures. France has endeavored to improve, in particular, the surveillance of cases of sepsis in the territory, to knowledge of the public on sepsis, and the training of health professionals to innovate for the prevention, detection, and treatment of sepsis. Concerted and global effort is necessary to decrease the burden of sepsis and improve its prevention, diagnosis, and clinical management. So thank you very much for your attention. I'll be happy to answer to your questions, ponder on a few points for discussion. Maybe I think the main point for us in France are the new tools for early detection. I think it's very important to share the new diagnostic procedures. I have one point, maybe we didn't discuss, about the role of young people, children, young teenagers, or young adults, helping us using new communication tools, social networks, to share the information, to explain to different people. And I think it was really one major point during this pandemic. Of course, the innovation and new treatments that we share very quickly, and maybe the importance of international mobilization, because we had a lot of meetings, we had a lot of exchange about, of course, big data, open data, GIZ organization, and I think it's very important to organize the debate, because we had maybe too many experts and too many papers to read, So I think we had maybe to think for.
I think we may have a tech. Thank you so much, Professor Salomon. I'm not sure whether it was only me that missed the last 30 seconds of what you said, but fantastic observations and insights. There is a great question that's just arisen for you, but I think firstly, and I'm conscious, I want to leave half an hour for a true panel discussion, so we've only got a few minutes. Thank you for shining a light on the links between COVID-19 and sepsis. This was highlighted by colleagues in Wuhan as long ago as April 2020. There's been a recent publication in one of the academic journals by Professor Jean-Louis Vincent to this point, and the Global Sepsis Alliance has a publication in Press around this. These are intrinsically interlinked, and I'm really welcoming of the fact that you highlighted the recovery journey. This is going to have a huge human burden as well as a fiscal burden. And I think there's huge interest in the data, and we can discuss this as we move forward to the panel discussion. But the specific question for you is, I think it's a great question. It can apply in other areas to other high-income countries, but what should the involvement of France be to support Francophone countries in Africa to tackle sepsis?
No, a major question. As you know, our president is really wanting and willing to help, of course, low-income countries through COVAX initiative or through HACTA initiative, through the multilateral organization, thanks, of course, to WHO. As you may know, in less than 1 month now, we'll have the World Assembly, and I'm sure it would be, of course, a major point. And I think, you know, the main idea now, thanks to our Chinese colleagues, is for the next pandemic to share the information very quickly, and to be absolutely convinced that we are now a little village. You know, we have to struggle everywhere, because if we let the African continent away and apart, it's a huge mistake. It's a huge mistake. So we have to share with them all the information we have, all the tools we have, all the treatments we have, and of course the vaccine. So, or we'll have a huge boomerang effect, you know, and it will be very costly and a shame for all the countries. So, I'm sure now this is a major lesson to call for help very quickly and to help everyone, of course, because, you know, through all the fights, all the flights we have, all the population moving, and we need, of course, to develop a lot of solidarity and you know, equity, because it was one of the lessons in France. Of course, we are facing a drama and a huge mortality, but the main mortality is observed in poor parts of France. In you know, in the suburbs of Paris, in the migrants, you know, organizations, and it's really a shame for other countries. You know, this importance of struggling against social inequalities, of course, geographical inequalities, because of course I talk about our islands and our you know, departments in South America, but really it's very important to be aware of the social and geographical inequalities and to fight against them. So of course we'll help all the countries that will call for them, but I'm sure, and you are right, that we have to help more French-speaking countries, not because they are French-speaking, but because it's easier only. And so the education, the promotion tool, the diagnostic tools, and all the help we can share with them is easier if it's French speaking. So that's only the point. And of course, we have a lot of in common in terms of you know, medical practices and education and university exchanges, of course.
Fantastic. And I note a point from another of our guests who reminds us that there are many French-speaking principalities and countries elsewhere in the world, including in the Caribbean. It is everywhere. And they make the point, actually, that in St. Vincent of the Grenadines, Saint Vincent and Grenadines, that there have been very few linkages with sepsis, which is interesting. And I think we would need to collectively look at those data to see, to investigate how robust they are, because we've certainly in the UK, and speaking to other colleagues in the Western world particularly, we have seen many cases, around 30-40% of people in intensive care with multi-organ dysfunction as a consequence. So we're going to move on from that. The point around Africa CDC and so forth. Very well made points. But I think we need to probably open the discussion now. And thank you, Professor Salomon, for those really interesting points. I have another, gold star question that really struck me. It was posted some time ago. I think I'd like to put this first to Marcus. It is a really important point, and one which I think the governments around the world need to be honest about and need to embrace. So the question reads, what are we going to do about healthcare needs that fell to the wayside during this pandemic? We're seeing advanced staging for newly presenting cancer, mental health exacerbation, primary care needs, falling by the wayside, the management of chronic conditions. So I suppose this is really around the unintended consequence, perhaps the disproportionate effect among lower income society members of lockdowns, of restrictions, and how we can mitigate against these in the future, and how we can help our healthcare systems to recover for all conditions. So Dr. Friedrich, could you take that very challenging point first, please?
Yeah, I think we have seen that as well in our data here from the state, that a lot of preventive visits were postponed during COVID, that a lot of healthcare practices actually shut their door. A lot of surgeries, elective surgeries, which is, colonoscopies and others, were postponed, and that we will probably grapple with the effects for a long time in looking at cancer incidence rates and also other rates that we already see as like slightly ticking up. It is a big issue, but again, I want to point to at that point when the COVID-19 overwhelmed the state here, that there was no other good solution in place to take a look at it. But it really brings up the question, Ron, that you were asking, what to do next. I mean, we know now what happened in the past. We know that this was not good for the health of probably a lot of underserved, but also some subpopulations who needed these procedures, but also the visits. And I think that one thing that I'm very proud of that the pandemic has pointed us more or quicker to is this effect of telemedicine and using other modalities than just going to the office and being checked up. I think that it will be not always a substitute, but I think that we have seen now, especially in my clinic and when talking to primary care providers, that probably 80 to 85% of the patients can safely be engaged in something like telemedicine. And telemedicine for me does not only mean like a glorified Zoom meeting, but it also means everything, the sensors and something like that. And I think that this will be, again, one of the effects of the COVID-19 pandemic, that this will be supercharged going forward, building systems that can take in these data from these sensors and also feeding that then to the caring primary care physicians. And I hope that this will spur, again, an innovation in care delivery. What we are doing here just actively, our Commissioner of Health, Dr. Zucker, made a public service announcement to promote actually preventive medicine, and also to bring this point really up and center, to say, go to your doctor. If you postponed a mammography or you postponed a colonoscopy, that we encourage you to go and see that. And I know that some of the providers who are active in the preventive health space, that they open up their practices for longer hours to make sure that this caseload has will be reduced, and that everybody can be seen and getting their preventive care. I know mammography screening appointments are really increased right now, which is a good sign, but that probably means that a lot of women have missed that during the COVID pandemic, and I don't know yet what the effect will be on the health of these people. So I think it is a multi-pronged approach to look at new techniques out there in a way of innovative, healthcare delivery, but also again promoting this. And maybe this brings, again, preventive health in the forefront again, how important it actually is, because it was, in a way, like an afterthought, okay, preventive health is primary care. Let's not talk too much about it. But I think it brings, again, this really onto everybody's agenda, that this is immensely important, and hopefully that will be also result in a rethinking of our approach as a public health agency to promote preventive health. We talked earlier a little bit about reimbursement. I, as a primary care physician at heart, I still have problems understanding why there is such a discrepancy of, if there's an orthopedic surgeon seeing a person for a, visit for muscle sprain versus, I deal with HIV and diabetes and everything else at the same time and get like a fraction of that reimbursed. So I think a multifaceted approach probably would make sense, but I'm interested to hear what my colleagues on the panel have to say about that.
Yes, thank you so much, Marcus. I'm really interested to hear Jérôme's reflections on this from the perspective of France, on the perhaps unintended consequence that may have been seen with a focus on a single condition. And I know Gareth has a point to make after Jérôme, but I think also I'd be interested to ask the Director General for Health in France, should there now be a diversion of some of the funds appropriated to managing COVID-19 toward reinvigorating public health campaigns for other conditions, urging people to access healthcare in a timely fashion?
Thank you. Yes, we did it since the beginning of the outbreak, because the management of chronic conditions and not COVID patients was really a huge problem for us. As you may know, everything in France is free. So there is no money problem for the patients, and of course it's very important to say they can pay and they can be of course cured and followed by the center. The organization is specific in France about cancer because we have dedicated cancer centers, so they go on following their patients and doing the exams, for example, or coloscopies and CT scans, for example. We had unattended conditions and maybe surprises. I'm not sure you had them. For example, we observed a reduction in cardiac neurological strokes through all the lockdowns. It's really unattended, unexpected. It's the same thing for mental health. It's changing during the countermeasures, and it's quite surprising to see that we observe less suicides during lockdowns, and that was not expected by our psychiatrist. We go on dealing with emergencies, of course, and even with transplantation, of course. We have a huge decrease in accidents, road accidents, of course, but even work accidents, and it's the same thing. We developed really very strongly the telemedicine. I think it's really a huge progress now. Everyone is doing this. It's free. It's covered by the universal coverage in France, universal health coverage. So we had a huge campaign, communication campaign in April to say, don't postpone all your medical examinations and exams and of course meetings. You have to go there. And we ask the hospitals and dedicated units to call the patients to say, come to have your examination, your follow-up and everything, especially the ID patients. What is quite new is the mobilization of different health professionals. We ask new professionals, nurses, of course, but also students, retired MDs and nurses to help. To go in front of the patients, what we call aller vers, which means go out of the hospital and please go to the patients. We developed a lot of nurse visits, for example, home visits, and it was very important. And we asked, and it's my last point, we asked patient associations to mobilize their patients to say it's important to be followed and it's important to have your examinations, your medical follow-up, and I think it was very important. So many points, but of course it was a huge preoccupation for us, and we tried to not stop the follow-up of all these chronic patients.
Fantastic. Thank you so much. That's a really honest answer. I'm hugely impressed. I haven't personally seen, as a consumer, evidence of such public health messaging around other conditions in the UK. So I'm really pleased that happened in France. My personal perspective is that is hugely important. I would reinforce your earlier point that France was one of the first countries to develop a sepsis national action plan, not before the UK. So obviously leading on this, which is great. A guest has made a point about the economic burden from lost productivity from COVID-19 and sepsis. I don't think we know yet around the lost productivity from COVID-19, but just from the UK perspective, we asked an independent health economics consortium to estimate the lost productivity per annum from sepsis in the UK, and it was £12.8 billion per annum. So lost productivity from COVID is going to eclipse that. This is a huge fiscal problem. Gareth, you had a point about delayed surgeries, I think, as unintended consequence.
Yeah, Ron, I mean, I think we just have to maybe just step back a little bit. And if we just look at the actual WHO's constitution, what is health? Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And I think sometimes we lose that perspective. And Jérôme and Marcus have talked about, different payer options. And we have in the UK what many perceive as free healthcare. It is not a free healthcare system. Somebody has to pay for it. The government has decided that this is the option that they will take, and they will fund it based on the economic benefit and the value created. So we have to look at this from an opportunity perspective in the future. Well, let's look at preventative measures. And what I mean from that perspective is, if by 2030 we need 80 million staff worldwide, and we know we will be short of 18 million by that time, what sort of opportunities are there in this preventative model? And what I mean is, if you see the growth of the wellness sector, which is, rising very substantially. Actually, I met Jérôme's colleague, the French ambassador, invited me to a session in Brussels where we discussed the growth of the wellness sector in France and across Europe. 50,000 new jobs being stimulated, for example, in a year. And these are huge opportunities, and then also an opportunity for the medical sector to bridge into that sector, to look at how do we manage quality and safety, because, from a cancer perspective, there's a lot of treatments out there that are not being looked at from a quality and safety perspective. So I think we have to look at how do we move investments into preventative measures? How do we create and stimulate new and meaningful jobs? And what I mean by that is, Ron, you know yourself, to become a nurse or a doctor, it can take up to 12 years. Okay. Some of these preventative measures, as in putting in a mental health, shall we say, solution into children's health and well-being in a school, we could do that within months, okay, and support children around self-harm. It would pay for itself very quickly because the economic cost of suicide is about 1.5 million over the course of tax, shall we say, income. So let's start to look at this from a point of view of value creation. And I'm sure Jérôme and Marcus could make these arguments very easily. But it's about now starting putting these cards on the table, because after COVID, I mean, I look at some of the stats in the UK. Primary care is now looking at 10% of the UK population. I think per week now that it's been ramped up because everyone is flooding the system. That's not sustainable. So how do we engage? And what I mean by engage, let's look at the sports agencies, huge resources in rugby, in football, soccer agencies. Why can we not engage social prescribing? National Academy of Social Prescribing in the UK is doing great work. The arts, they've hit, all these areas are sectors that need investment. Why don't we look at how do we invest in these areas? And why don't we look at something from a long-term perspective when we're raising bonds and finance, not on the short-term look? So these are opportunities I see, Ron.
Yeah, no, that's fantastic. This kind of recalibration of our expectations around healthcare system funding, around how we prioritize the appropriateness of resource allocation to preventative medicine and non-preventative medicine. It's a hugely refreshing attitude. It's almost just taking it back and redesigning the system. There's a long way to go. And I think, there've been multiple questions arising, Gareth, and relevant to others at governmental level. Should this money follow into WHO programs, national departments of public health, NGOs? Do we need a circular economy and so forth? So, what do you think, Gareth, and others think would be the mechanism for this recalibration of prioritization of preventative and non-preventative healthcare?
It has to complement the existing system, and we can create a circular economy. As I said, there already are systems in place. We have to use it, look at new mechanisms, new platforms, new ways of dealing with this. Look, we've a lot of clever people in the world, okay? We can learn from the Googles, the Facebooks, but let's do it ethically and transparently. Let's look at this supply chain. Let's look at the health system, which is a $12 trillion market space. We have prototyped certain solutions in the UK that can give £1 invested 36 back. Jérôme and Marcus can do the opportunity cost on that. It's substantial. This is how we can drive new ways and new opportunities. I will say that the G20 in Global Solutions in Berlin meets next month. We will meet with Felix Tshisekedi, who is the president of the Democratic Republic of Congo and the chair of the African Union. And Africa and South America and Asia, they have they will come to the table as well because the need is so great, and they could actually revolutionize healthcare because they could look at this preventative as a huge opportunity for them.
Thank you so much. Anything to add from the perspective of New York or France, or general observations, Marcus, Jérôme?
No, I think these is a great discussion, because I think that something like a COVID-19 pandemic has to also spur some of these discussions and basic understanding and fundamentals of health systems around the world. What, how you started in the beginning, Ron, asking what went well, what are the lessons and so forth. And I think that this will, again, bring us to this level of thinking about preventative health in a new way. System change in the United States and in New York is extremely, extremely hard. But I think that maybe the time is now to at least start a discussion, engage some of the stakeholders in this, and really put it out on the table and say that how can we think about preventive health and design healthcare around the patient, something that I think the Global Sepsis Alliance and others are always advocated to have kind of the patient in the center, then institutions or other stakeholders in the center, and build the system around that. And so I think those are some of the ideas. We have, especially with the question about health equity, we have started asking those questions internally, and have engaged in a discussion about kind of like what should we do in the next couple of years. And I think it again comes to the point that a strong primary care base, which you have in Great Britain and also in France, and are really much better situated than the rest of the world, that is really a fundamental need for answering these questions, and also making the next move then and engaging patients stronger in this preventive health space.
Fantastic, thank you. Anything from yourself, Professor Salomon, on that point?
Yes, thank you. Just one point, the global cost of this crisis in France is estimated around 400 billion euros. So wow. I am sure this is not the last crisis, but this is the first major crisis of a new era. There will be more crises, emerging infectious disease, pandemic, and of course, environmental crisis, climate changes, impact and everything. So prevention is really a major point through anticipation, preparation, innovation, of course. But my point is we have to invest in humans. We lack a lot of human resources, MD, nurses, ICU specialists. We have to find field epidemiologists, people to be able to do contact tracing, nurse visits, and help people to correctly be isolated and everything. So I think the cognitive response is crucial. We need more social studies to evaluate the psychological conditions, why people don't want vaccination. I think it's a huge problem. It's very, very, important for us. Of course, everything is important, big data, open data, artificial intelligence, but invest in humans, I think it's really important for all the countries.
Fantastic, thank you. That is a beautiful segue into the final collection of questions from the guests here present. There was a lovely observation that there was a pop song created in Vietnam around viral prevention and stopping the spread, which did an enormous amount, but it also links to some other points made around the point you made, Professor Salomon, around vaccine hesitancy, around a point that another guest made, that in Ecuador, the public simply don't listen, they don't behave, there's lots of mass gatherings. My question to the panel is, in the age of information consumerism, in the age of super rapid dissemination of information, in the age where a high school student has the confidence to access a scientific paper and appraise it for themselves, have we misjudged the level of trust we need to place in our public and the granularity of information they merit in order to get them to behave in the right way without diktat?
I'm happy to just chip in here, Ron, just to say that, trust is the oil of the future. I think we really need to look at this. And I think going forward, we have from a public policy perspective, let's also just look at what we have established. In 2015, 193 heads of state stood up and agreed to the 17 Sustainable Development Goals. And we already have a compass, and we already have, shall we say, a direction. And as Jérôme and Marcus are well aware and mentioned, climate change is coming around the corner, and let's be dead honest here. This poses a huge health risk around the world. And I think it's very important that we begin to stitch this together. Biden administration tomorrow will have a summit, but how many health ministries have been invited? Because I think the impact from a health perspective is enormous. And we need to start to think holistically around how do we bring everyone to the table, and also trusting next generation, and how do we inform people, and then health literacy programs in schools. But also we have to look at mitigating long-term health problems through family planning and engagement, pregnancy, well-being, women's empowerment, gender equality. All these things are on the table. But let's use our wisdom here, because we have quite a lot of knowledge. This panel, is engaging in multiple fronts, from sepsis to COVID-19 to lessons learned. There's so much information out there. But let's start making action, let's start doing things, because we don't have time. That's the unfortunate thing, 2030 agenda, when I see statements come out about net zero by 2035 or 2050, look, Bosch, the German corporation, are already net zero. Okay, let's follow best practice and let's start engaging and amplifying those messages and leadership. So.
Thank you, Gareth. Jérôme, Marcus, any comments on my challenge, I suppose, around has the messaging been right? Do we need to engage our next generation?
Yeah, I'm sure we need. Thank you. We are trying to fight against vaccine hesitancy through using, social influencers. And we need to give examples for people, through brothers or sisters. And in France, I think it's already the same thing in US or in the United Kingdom or in Germany. There was too many informations, everyone, each MD, each nurse was the specialist on 24/7 information channels. And of course, I think there are many levels to use, of course, the WHO mobilization, the European solidarity, the national message is very important to see there is a strategy, but we need local communication. You are really listening to your pharmacist, to your MD, to the mayor, to local influencers. It's very important, using cultural approach, using, of course, different languages. And for example, pictures for children, and a lot of schools try to explain the pandemic through pictures, through drawings. And I think we have to use all these tools to share information.
Thank you so much. No, that's a great answer. Marcus, any perspective from you from a New York State?
Yeah, I think you're right, Ron. I would not say if we completely misjudge, but we are far behind the curve in our response. And I think in how we share information, how we use data, that the current generations is probably more advanced, and we are still in this mindset of how do we serve the elderly generation. And I think we have to really adapt a new strategy, bringing information into the hands maybe of the individual, and how that is. I think social media is here to stay. We've seen that. I get most of my information not from the TV anymore or the internet. I use Twitter and all the research papers, all the thoughts that are being shared there is just remarkable as a global community. And I think that we have some catching up to do as a health agency to really engage on a new level with our constituents, with our patients, and with the people on the ground. And I think that this needs probably like a new thinking about how to use data and how to use information. You also mentioned trust. I think that the public usually is still trusting of the institution in itself, but we could probably do a better job in pushing out the information and making people aware of that.
Yeah, well, I would like to thank, both of our colleagues who are engaged in national and regional government levels for their candor in their response to that question. It was, of course, a challenge. We have 1 minute left. I'm going to pre-warn the three panelists that I'm going to come around the room in no particular order and ask for one sentence of a closing remark or a take-home point. So in no particular order, Gareth, please, a closing remark.
Thanks, Ron. I think this has been just an invigorating session. And from my perspective, I'm just delighted to meet Marcus and Jérôme. I very much look to the future. And I think this is an opportunity. I mean, the Sepsis Congress, listen to earlier sessions. I feel really proud to be part of the medical community because we are operating with openness and transparency, and we are trying to build that trust within our communities. And let's go out and let's meet it head on. Perhaps in the past, what we've done is we've sat back and waited for the cases to come to us. Perhaps one of the lessons from this is that we go out and meet this head on, and that we go out and fight the disease, shall we say, in our communities and help them manage this pandemic. So I'm just full of optimism. Thank you very much, Ron, for hosting it. And it's been a pleasure joining the panel.
Thanks so much, Gareth. Rather more than one sentence, but it comes with the nationality, I believe. So, Jérôme, anything from you? Closing remark?
Well, it's very short. I think the last pandemic was in 1917. So we with this COVID-19 pandemic, we knew approximately nothing. And we have to share the lessons globally, and we have a lot to learn for the future. So the main question for me is how to transmit all we have learned, to the next generation, to be sure that in many decades they will never forget what we did and what we did not very well. I think it's very important, to share very honestly all the lessons.
That's a hugely important comment. Thank you. Marcus, the final comment from yourself, please, and could we keep it brief?
Yeah, any big disrupting event, such like COVID or any pandemic, will give us as a society great opportunities. And I just hope that we will take those lessons and apply them for the future to make it a better society.
As we say in the UK, hear, hear. So I'd like to thank our three panelists, Gareth Presch, Professor Jérôme Salomon, and of course, Dr. Marcus Friedrich. Great conversation. I think there'll be lots more of this on social media and following. Thank you very much.
Thanks
very much.
Thanks, everyone.
Thank you.